Okay, so I'm going to be talking to you all about improving the metabolic screening of diverse populations with severe mental illness. And I just wanted to give you kind of an overview of what I'm going to be talking about today. So first, I'm just going to make sure we're all on the same page because I don't know how much baseline knowledge you all have about the issues of metabolic syndrome, treatment, and screening among people with severe mental illness. So I'll be talking about that. I'll review my previous work and then the current studies that I'm doing here at San Francisco General Hospital. And then ideally some opportunities for collaborations with folks here in DJ. So my disclosures, my current funding is with an NIMH K23 award, and I also have a Hellman Family Fund award. And then studies that I'm going to be talking about, these are the pharmaceutical industry sponsored studies. These were before when I was a resident. So APIRE is actually part of the American Psychiatric Institute's American Psychiatric Association's research arm. And so they with the pharmaceutical industry, used to fund residents to do research. So this was a resident grant that I got, and this is one that I got during my fellowship, was a research, basically a research fellowship through the APA. And this is NARSAD, which is another foundation grant that I got. So some of my work is funded by these. And then you all are probably more familiar with CADC, that's here through UCSF. Thanks to Kirsten and others in the KL2 program. I am KL2 scholar, and then I got one of the RAP awards for underrepresented minority faculty. I'm Latina by heritage. It's not easy to see by my name, but my mother is from Ecuador, and so I identify the most with that culture. Okay, so this is me, actually, circa 1991. I grew up in Bethesda, Maryland, so I wanted to kind of give you more of a big scheme of things. So I grew up in Bethesda.
I was like, what a nerd.
That's nerdy. This is me working in a lab. I did a lot of southern blots and northern blots, which, as I learned, is kind of from a lot of the geneticists. They don't really do, everything's more sequencing and on computers now than this. But I used to do this. And I love this work because it was really intellectually satisfying. I loved doing research. But I think what I didn't like about it was hard for me to see how this was going to directly impact patients. And like I think most of you who are here in the room, when I came here to medical school and I did my rotations here at San Francisco General Hospital, that's when I fell in love with this hospital. And I fell in love kind of with the mission and with the doctors here, people like you who are providing care to patients. I remember rotating with two folks that you guys may be familiar with, David Bangsberg and Rebecca Sudor. David was my attending, Rebecca was my PGY3. David was definitely upset that I was going to psychiatry and not medicine. He was very vocal about that. But I remember seeing those two people and being like, I want to be like them when I grow up and really treat this population. So this is when I started getting really interested in actually services research and improving the care of the population. So then I went out to Columbia, to New York, and I did my psychiatry residency there. And this is actually a picture on the right of one of the inpatient unit rooms there. And they have this great inpatient ward that basically serves a predominantly Latino population, but they're Dominican. They're from Dominican Republic and the Caribbean. And that's because of the area in Washington Heights where Columbia is located. There's just a large Dominican population. This was a community service, so a lot of the people on the wards actually some people spoke Spanish, the staff, not so much the psychiatrists actually, but the staff, and a lot of them were Dominican as well. And so I was on my PGY2 rotation, and then I had this 20-year-old kid who had schizoaffective disorder, and we put him on Zyprexa or olanzapine, which some of you may know, that medication. And because he was having these command auditory hallucinations to kill himself, he was really paranoid, and he gained a ton of weight. So I was a good PGY2 doing, my journal club, and so I did this journal club, and there was actually a study that was done, and actually it was more of it was a consensus group, and so it was published from the ADA, so the American Diabetes Association, and the APA, the American Psychiatric Association, joined together and said, hey, there's some evidence that these medicines, this was like in 2005, there's some evidence that these medicines can cause metabolic complications like diabetes. We should be doing testing, and you really should be screening them for lipids and their baseline fasting glucose first, and then monitoring it every 3 months or whatever. And so I was like, oh, we should be doing this. So then I gave a journal club and I started writing orders for fasting lipids. And the nurses, this was a standalone psychiatric hospital that was attached to the main medical center. So what are you doing ordering these? We don't know how to get these labs. Like, how do you get them? What tube do you put it in? And so it was very clear to me at that moment that this was obviously not happening, right? Like this, that nobody was getting screened. And so I was like, oh, but this paper says we're supposed to be doing it, and why aren't we doing it? And I thought, well, is there some sort of disparity in care? Are they not getting the right care that they should be receiving? And this is when I got really interested in improving the medical treatment of these patients. This guy actually went on, interestingly, to be put on clozapine because he was really pretty refractory to treatment, and then had myocarditis, which is a very rare side effect from that. But he came up as a 20-year-old with crushing chest pain and said, I feel like I'm having a heart attack. And the internist was like, there was an internist that was on the unit, and he was like, no, he can't be having a heart attack.
Oh, really?
Yes. I had to push for, this happens over and over again for psychiatric patients. They will present, this is not uncommon, they'll present with different symptoms and people will say it's just their anxiety. This is not, you know, anything to worry about. And I think particularly the problem, especially with this population, is that they present with symptoms that people don't anticipate to be coming from somebody so young. And so they just, you don't think about that in a 20-year-old that they're going to be.
And just because not everyone's a clinician, so like schizophrenia, the 20s would be the prime presentation time.
Exactly. So normally, like you think about it, 18 to 22, kind of sometimes like around college when people be going young adults, and that is the prime time for that, along with bipolar disorder. And so severe mental illness I'd classify as being like schizophrenia, schizoaffective disorder, bipolar disorder, even major depressive disorder if it causes such impairment that they really can't be going to work or do anything like that. Okay, so this is the literature on these people. So the take-home message for all of you is this, you know, like you're supposed to leave a talk with a few items to remember. This is the one item to remember. So this population, and why I think both Kirsten and Dean have been interested in my work for the center, is that this is a very vulnerable population. They're dying 25 years earlier than the general population. And does anybody know what they die of predominantly?
I don't know what the predominant one is, but one of them is suicide.
Right, and so that's a really great fact. So a lot of people thought, wow, well, the reason why they're dying is they're all killing themselves or killing each other. You know, this is what's happening. They're dying, exactly, they're dying of heart disease. And so they actually went to these there was a Medicaid sample, and they looked at these different states and they separated out suicide. I don't have the slide on this, but they separated out suicide from cardiovascular disease. And they're like everybody else. They're dying from the same thing everybody else dies from, they're just dying earlier. Okay, and so there's 20 to 50% of deaths in these states. And what's interesting is that, you know, this has been reported actually in newspapers. This was in the San Francisco Chronicle, it shows this. There was an article on USA Today that I have about this. So patients are aware as well. So,
But why are they dying earlier?
Why are they dying? Well, that's exactly what, I think there's a lot of different reasons. So we'll be getting into that a little bit. But one of them, I think, is this, the higher incidence of the metabolic syndrome among these patients, and some having to do with the medication. So does anybody, who here knows what the Katie trial is? Okay, so the Katie trial was published, I think, around 2005, and it was in the New England Journal. It was basically this landmark article, which it took, it was a pragmatic clinical trial, so it took about 1,500 people with chronic schizophrenia, and they were, you know, chronically treated on these different medications, and then they randomized all those patients to different medications, okay? And so a lot of them were on second generation antipsychotics, and the big finding of this study was there was really no difference when they switched the medicines, even to one of the older medicines, perfenazine. And so that was a big finding about this study. But the nice thing about this study, too, that you can see, that one was in the New England Journal. It was by this guy, Jeffrey Lieberman. And the nice thing is that they collected all these facts about this population. And so you'll see a couple of my slides are about the Katie trial because it's a great cohort of patients. So one of the things here, you all probably are more familiar with NHANES, right? And so they compared Katie patients, so we think chronic people with schizophrenia, compared to NHANES subjects. And you can see Katie's in orange. They got males and females both have much higher rates of the metabolic syndrome, especially women. You can see how much more dramatic. And then this is a nice study that was a meta-analysis looking at rates of diabetes. So this is basically, these are a bunch of studies on schizophrenia here, and this is bipolar disorder, and you can see the risk ratio is 1.7, and if you just took patients with just schizophrenia, the ratio is actually even higher. that. So this is just looking at diabetes in and of itself, the risk of diabetes, not the whole metabolic syndrome. Okay. So why do you guys think so many of these patients are overweight, obese, or have the metabolic syndrome?
Well, if they're depressed, then they have no desire to do anything.
That's good. Anybody else have any? So one is not not exercising.
Right.
Well, I'm sure you know, is one of the other answers to the medication.
Right.
Yeah,
So a lot of people are particularly concerned. I think you mentioned this earlier about the medications, right? And so treatment with antipsychotics, but I was actually happy to hear you say something else because this isn't the only part of the story. I think the medications are the part of the story where the clinicians can have a role in adjusting this risk, you know, more easily because we're the ones prescribing these medicines and or we're the ones that are monitoring the metabolic risk, but it's not the only culprit.
But what is it about the meds that the
Just-
meds themselves cause metabolic syndrome?
Yeah, and different medications have different levels of risk. So you can see, like, they look at these second generations and antipsychotic medications are the best studies. So there's this good article by John Newcomer, basically outlining the different medications, and some of them appear to affect insulin resistance. The exact mechanisms a little bit unclear. I mean, there's some effects on the serotonergic system and the histamine, but I don't know if they don't know exactly why it's causing as much of these metabolic side effects. They just know that some of the medications tend to cause it more than others. So the two big hitters, who do people know what they are? As far as antipsychotics are concerned, clozapine and olanzapine. So if you see any of your patients on clozapine, which is actually a really great drug for treatment-resistant schizophrenia, but that one and Zyprexa are the ones that typically cause most of the weight gain. Then kind of in between are Risperdal and Seroquel, and then the lower end of the spectrum are Abilify and Ziprasidone. So this just shows, basically this is another one from Katie, but shows olanzapine causing weight gain. This is after a month in treatment when they randomized all the patients to these different medications, and those randomized to olanzapine gained weight, quetiapine, Risperdal, whereas perfenazine and ziprasidone, there was weight loss.
So you're missing your y-axis there. How much weight is that red bar?
There was, it varied. I mean, I think it was like in the month, it can be up to, I think it was 2 or 5 pounds. It was a lot. Mm-hmm. I mean, they gained a lot of weight very dramatically, but I should include that in there. And this is just to show how much of a shift there was as far as prescription practices. So this shows prescription of antipsychotic medications over time. And so this is, the excess is 95 through 2008, and this is the number of prescriptions. And you can see basically the take home is the light gray is the typical antipsychotic. So these are things like Haldol or Thorazine. And these are the second generation antipsychotic medications like olanzapine and Risperdal. And you can see that basically this is from pharmaceutical industry marketing and direct-to-consumer advertising and to psychiatrists and internist advertising. But you can see that the second generation antipsychotics take the market share of the antipsychotic prescriptions.
And the metabolic risk is not seen with the typical.
That's not true. So I'll show, yeah, so I'll show this. This is more about the weight gain. This is actually showing how much weight change also happens among kids. So kids appear to be particularly vulnerable. But I think I have the next slide. It's one of these other ones. But no, I'll show a slide with that. So are there guidelines for monitoring risk? I actually kind of answered this myself, but do you guys remember what I said?
That they were, but nobody was following them.
Right. So there are these guidelines, yes, and the ADA, APA monitoring guidelines. And so they were actually in 2004. And what they recommend is actually at baseline, you're supposed to be getting a personal history, a weight, waist circumference, blood pressure, fasting glucose, fasting lipid profile, and then every 4 weeks, 8 weeks, 12 weeks, quarterly, and then annually. And so that's how you're supposed to be doing this.
And what are you supposed to do with that information? Just put people on metformin sooner?
This is the problem with this whole thing, actually, is that there's and with my work is kind of showing too that there's this disconnect with the screening and the treatment. Mm-hmm. And so I will never forget talking, while I was doing some of this work in New York, talking to this psychiatrist who was like a beloved, awesome psychiatrist, was very, senior attending. And he said, Christina, why would I check the blood pressure? And he said, what am I gonna, if it's high, what am I gonna do with that? I don't know what to do with it. So why would I check it?
Yeah, good point.
It actually is a reasonable
Yeah.
point if he doesn't
Yeah.
know what he's going to do with that, or if there's nowhere to send it.
Right.
So, but this will come up, and I'd be very
There's a
curious.
method to that, right?
What?
You treat it, no?
Well, right, and so you would treat it, but the psychiatrist actually, like I got actually pretty heavy dose in my training of medicine, so most residency programs don't have as much, but I did, but all mine was inpatient. So you had a lot of managing heart attacks, PEs, strokes, on neurology, etc., but I never had any outpatient medicine. So I never had any training on how to deal with dyslipidemia, hypertension, just regular monitoring of diabetes, and that's a problem. You know, because most of the psychiatrists are actually where these patients are seeing their care. That's who they're seeing regularly, and that's my whole thesis is kind of, you know, really the psychiatrists, I think, should be empowered and helped to be making some of these preliminary treatment recommendations.
Do they usually refer them to their primary care?
So that's the ideal, right? That's what everybody says, well, of course they should be going and seeing primary care, and that's of course true, right? If they can make it to primary care. So a lot of these people are very disorganized and don't make their way to primary care. And a lot of the doctors here are very great and nice and just go by guidelines with their patients. There are some other physicians who kind of are very stigmatized against this population and say, well, Joe's has schizophrenia, there's no way he's going to take his Lipitor, so I'm not even going to prescribe that. So that happens a lot, you know. Okay, but it's not just, so this is your answer, Kirsten. So this is actually something that I put together with a work group in New York, which actually was looking at metabolic risk profiles of all the antipsychotic medications. And the thing to notice here is that we did oral antipsychotics, and there's, for example, thorazine, right? That's a first-generation antipsychotic medication, but it has huge metabolic risk. So people will say, oh, it's just the second-generation ones. No, it's not. It really varies, and you have to be paying attention to different risks. But this isn't very accessible to a lot of different people. It's starting to be. And this gets to your question that we talked about before, right? And this is a really interesting study done by this woman, Elaine Morado, who's in Colorado. So she looked at Medicaid sample in a few different states, and she was looking at what happened after the ADA consensus statement happened. And this was percent of people receiving baseline lipids, percent of people receiving baseline glucose testing. And she was actually very open to her definition of what baseline glucose testing would be, whereas even getting a Chem 7 was okay for her as doing that. Didn't have to necessarily be fasting. And you can see here that there was no real change, right, in glucose testing, no real change in lipid testing after these guidelines. So these guidelines are there, but they're not necessarily being implemented. And then you might ask the question, okay, if they're getting screened, then are they getting treated? And the problem is that's not happening either. So there's a lot of, this again is from Katie, and you can see that for these different illnesses, this is the percent of untreated patients, and it's the most notable among the patients who have dyslipidemia, that 88% of them are untreated.
But when someone would screen and see that a person had one of these disorders, then is it obvious that what they ought to do is treat, or is it another option is to find a different antipsychotic?
Well, yeah, and I'm going to get into that too. I mean, I don't think it's always so obvious. So I think that, or so straightforward, and that's what can make it a little bit complicated. You might just say, well, why don't you just switch the medications? Well, sometimes people don't want to have their medications switched, right, or they've tried a bunch of different medications, right, and that doesn't work. Yeah, or there's a right way to switch it, but then they don't. You know, then there's.
They're coming over.
Yes. This is Jim Dilley. He's my boss and mentor. He's the chief of psychiatry here at San Francisco.
Thank you so much for
He knows my work well.
Yes. Sorry I'm late. How are you?
Nice to see you.
And the significant part is that non-white women also had really significantly lower rates of treatment than their male counterparts. And this I also thought was a really interesting study. So this was looking at people with schizophrenia, people who had diabetes, and then it stratified it by people who had schizophrenia and people who were smokers. And so this is, I think, kind of is alarming. So you have here in the light blue, this is, for example, if you had diabetes, and let's say starting an ACE or something, and you were a non-SMI, non-smoker, they had a 50% chance of being started on an ACE inhibitor. If they were a non-SMI smoker, they had a little higher chance. But if they had schizophrenia, which is the pink, it dropped down their likelihood of getting treated to 20%. And if they had schizophrenia and were a smoker, which you would think is kind of counterintuitive, they even had less of a likelihood of getting screened. And I don't know really what this means other than we're not doing a good job in screening or treating this population. And our population of patients know people with schizophrenia who smoke is enormously high, for those of you who don't know very much about people with SMI. Okay, and this is just a slide saying, you know, there's tons of studies on this, but people with severe mental illness less likely to be screened for all these metabolic risk factors that we talked about, less likely to receive angioplasty or CABG, less likely to receive drug therapies after MI, and more likely to have premature mortality after MI. The list can go on and on with almost every disease that you can think about. The mentally ill are less likely to get treated. Okay. So as we talked about you know, the lack of training that psychiatrists have for treating primary care issue, you know, one option for people who have, you know, these metabolic side effects of these medications is to focus on their weight loss. Let's say you can't actually decrease their, change their medication around. And so there's some different options to help people lose weight. So you guys had Gail Dommett come, right, to the Department of Medicine. Did any of you guys see that?
Yeah, that was a little while ago.
Yeah, I think in May. I think in May.
Exactly.
So she just did a study. She's from Hopkins, and she's an internist, and she did some work basically on looking at a weight loss program for people with schizophrenia. And PORT, which is basically Psychiatry's Cochrane collaboration for schizophrenia, like they're focused really on reviewing the literature for schizophrenia. PORT has made recommendations on weight loss. And they actually say, because a lot of people say, you know, you were mentioning about exercise, they'll say, well, they have schizophrenia, they're not going to be able to do a weight loss program. But actually, study after study has shown that, yes, they do. They actually go, and it can be very effective. And so what they recommend, which is similar to other populations, they recommend it being 3 months in duration. They recommend behavioral self-management, goal setting. They want you to weigh in, you know, to know how often, you know, what your weight is like over time. They encourage monitoring of exercise. And then this is actually addressing your issue, I guess, about switching medications. So PORT and Cochrane, so again, two groups that have looked at the literature closely, neither of them stand very strongly on this issue to switch medication. The evidence is very limited. So they basically, PORT, and this is a quote from the PORT guidelines, is silent on areas where research findings are suggestive of benefits, but the opinion of experts can't be elevated to recommendation status because basically the sample sizes are too small. Again, Cochrane says the same thing. Although the ADA-APA guideline says, which makes kind of common sense, when you're starting somebody on these medications, you might want to think about starting them on medications that are less metabolically risky, and that you at least want to be considering switching the medications in that patient if they would like to. And this is another kind of study. Again, this is by Rosenhack, and this looks at, again, in the Katie trial, and they had patients, you know, because one of the nice things about that trial was it could do a stay versus switch model. So some people came on and stayed on olanzapine, and some people came on and then were switched to other medications. So these are of all patients who were on olanzapine, which again is a heavy hitter. When they came in, they continued to develop, you know, increased weight over time. But if they were switched to basically any of the other antipsychotic medications, they lost weight.
So, but this data seems pretty good.
Yeah.
Right.
It seems pretty clear. Why are the recommendations like more equivocal than this?
I don't know. I'm not sure, but I know. I mean, I don't know if they could base it on just this one trial. So again, you know, clinicians can modify obesity using medications, even though I do think it's worth us considering, even if the evidence isn't totally there for us, simplifying the medication regimen, behavioral interventions, and that antipsychotic medications are associated with different levels of risk, and we really should be paying attention to high-risk populations. Oh, this, I'm sorry, it was misordered with the special populations to consider. So there have been some studies, not a lot, but some studies looking at different high-risk populations, and it looks like certain populations, certain racial and ethnic populations and certain age groups appear to be higher risk. So African American outpatients receiving antipsychotic agents had significantly higher rates of obesity. They were also more likely to develop side effects from the antipsychotic medications, particularly clozapine. Latinos had a higher prevalence of abdominal obesity and metabolic patients than schizophrenia patients in general in Katie, or Hispanic patients in general in Haynes. And although the sample was really small, there were, I actually called the authors about this, but in the Katie trial there were 15 Latina women, and the prevalence of metabolic syndrome among them was 85%. And he's like, yeah, it was like really remarkable. But again, the sample was only 15. Women, again, are at high risk for the metabolic syndrome, and then children. And so this is something that I think is important for kind of more generalists to be aware of, because there is a lot of use of antipsychotic medications for kids that's not even for kids who have severe mental illness. Sometimes people will use it for ADHD, for refractory ADHD. People will use it for adjunctive medication if somebody's mildly depressed. There's a lot, you'll always see things like, oh, just add a little bit of Abilify if you know, and you'll see these in, yes. Yes. And it looks like these populations are particularly high risk for developing these metabolic complications. So I think of them as a high-risk population. So among kids, 6 to 17, again, who are receiving these antipsychotic medications, they have 3 times the increased risk of developing diabetes. So this to me seems like prevention, right? You get to these kids early, then they're not developing diabetes, their lifespan lengthens. Okay, so then I'll go into some of my work. So I'll go, these are, first is kind of smaller studies, and then I'll get into the work that I was doing with my, in my K. So when I was in my residency, as I talked to you about, I was on that inpatient ward, and I basically did a really small cross-sectional survey study of the patients and a little chart review. And the most pertinent findings that I found were that although 98% of patients on the unit had their height and weight recorded, that was nursing did it, only 6% had their BMI recorded. So to me, what that was saying was only 6% of these people, only 3 of these patients, did the doctor, resident, or whoever actually look at the chart and be thinking about the BMI. Nobody was actually thinking about it. And then, so even though 40% of these patients were obese, they really should have been paying attention to it. I actually got the BMI now to be a required field in the discharge summary for the residents. And the other finding that I had from this study, because I was convinced that probably these patients would want to just add medications on if they had any kind of metabolic abnormality, but actually they didn't want to add medicines, they didn't want to change their medicines. What they wanted is they wanted a behavioral intervention. They wanted a weight loss program. So that's actually what led to my second study. And so this was the NARCET-funded study. And so I did a quasi-experimental trial, basically enrolling patients at 2 sister clinics, again serving a predominantly Latino population. And I looked at the effect of just basically usual care. We gave one nutritionist came and talked to them about the importance of eating healthy food. But then we did a weight loss program that was based on that 3-month treatment. And basically it was incredibly feasible to implement, and it was acceptable. 68% of the patients attended over half the classes. Unfortunately, we didn't see much of an effect, and this had to do with the prescription practices between the clinics, and the clinic that had the intervention happened to have more patients who were on olanzapine than on risperidone, which was a less weight-inducing medication. It was a problem with design. But it was incredibly sustainable, and actually the class is going to this day, that the patients actually wanted it to continue, and they do exercise during the class. They often go on a walk right after class. And I've been approached to replicate it for different samples. So then I'm going to breeze through this section so we have some time to talk, but basically, when I was in New York, I had this great opportunity when I was at Columbia, because I had been working on this area, and there weren't actually at that time that many people who were interested in this. But the director of the Office of Mental Health in New York State was actually very interested in improving the health care of his population because of this data showing that patients were dying 25 years earlier. And I was kind of at the right place at the right time, and he asked me to kind of lead this initiative in New York State to improve the health screening of patients throughout the state. And we started on the inpatient wards, and that was very easy to do. And then we were trying to work on the outpatient clinics. So this was basically, the plan was to do something very easy and straightforward, ostensibly. Now, for those of you who are here in medicine, this sounds stupid, right? That you would check somebody, that it would be a huge thing to check blood pressure and BMI and smoking on your patients. That is a huge, this was a hurdle to implement this across our system of care. One of the big reasons being there's no nurse that's kind of up in the front that just goes and takes patients in and does these things. And the staff, there's no electronic record a lot of the time that had any place for this stuff to go into. So we actually chose these 3 indicators, and lab tests were intentionally excluded because that was thought to be too much of a stretch for our system of care. So I took basically 5 implementation steps. First, we defined the population. So there were 17 of these psychiatric centers that were wrapped around hospitals and 66 associated clinics. And so this equated to about 15,000 unique patients. So we wanted to define who are we going after. And then we made sure, did everybody have scales? Does everybody have blood pressure cuffs? Working closely with the medical directors so they had what they needed, so they couldn't say, well, we didn't have our cuffs, so we couldn't do this. The electronic database, so I worked closely with a lot of the people on the ground to create a monitoring tool that was acceptable to them, that was easy for them to do and navigate. That was right on the main part of the EMR. And then we did regular performance monitoring, and I set up quasi-learning collaboratives where I would have the medical directors or clinical directors all call in once a month to talk about how it was going. And so this is the metabolic monitoring tool, so you can see that this was like the front page, what they would see on their medical record, and then there's the metabolic monitors that they could click like kind of right away there. And then this was pretty easy, so these are obviously fake patients, but then it was easy for you to type in the height, the weight, it would calculate your BMI, you put in the blood pressure, and smoking status. And so if you were, if it was red, if the person was in red, it was overdue, because you were supposed to be doing this every 4 months. And so then we did the performance monitoring. And so this is the monitoring that we did. And these are, I'll show you a series of 3 different graphs. And so this is the percent. These are 2 different things. So this here I'm focusing on BMI. And so this is people getting just the BMI readings. And these are the people who are overweight or obese among those who were screened, okay? And these facilities are different facilities in New York, so they're different, basically, hospitals that were affiliated with different clinics. And so when I would give performance, what?
In where?
In New York State. So when I was talking, I would give to the clinic director, you're K, so they would know, oh, I'm K, I'm better than the mean here. And my patients, if I look over there, they have this amount of prevalence of being overweight or obese. And so what you can see is that we got up to, and after 4 months, we got up to about 50% was the state mean. And what was, not surprising to us, but the proportion of people who were overweight or obese was 80%. And so this was pretty, this was useful information for the medical directors to have. So this is the same slide again, but this is for hypertension. So again, we got up to about 50%. Only 27% in this case looked like they're hypertensive. The problem with our monitoring of this is that we didn't have the link to the medications that they were taking, so that we don't have, like, let's say somebody was well controlled on an ACE inhibitor, we wouldn't count them in this. So this is likely an underrepresentation of how many people had hypertension. But this is not, this is smoking. And so you can see again, we got close to 50%, and then almost 50% of the people within the system were smokers. And that's a lot, right? Okay. So as you can see, there were substantial differences in performance between the facilities, and we targeted efforts on those that were really low performing, the 25th percentile. And in 4 months, we had 75,000 people who were screened, and we could see how much of an extent of a problem these indicators were for our population. Okay. So then, thanks to Jim, and timing worked out right. I again had mentioned to you all I went to medical school here at UCSF and then got a residency at Columbia and was working there as an attending. And my husband and I had a young child in a one-bedroom apartment in New York, and we're making the decision: do we move to some place like Westchester, or do we move back to California? Not that we get so much more room, but we get more room than we did in New York, and a nicer room and be able to exercise outside. So. Nicer weather, definitely, and family. We had some family out here. So anyway, it all collided, and it was really fortuitous that I got to meet Jim, who's been just a fantastic mentor to me. And so then that began kind of the work that I started doing here. And again, my overarching goal is to implement programs to improve metabolic screening and treatment of diverse populations with SMI. So what my kind of question is could we really start conceiving of these community mental health care clinics? So you guys, do you know what a community mental health care clinic is? Okay, so you have a primary care clinic, right, like the GMC, right? And then you've got other places like the Mission Mental Health Clinic. Have you heard of that? Or Citywide Focus, places like that. Those are community mental health care clinics. Okay, and that's typically, there's a psychiatrist there. South of Market Mental Health Care Clinic is an example of those. That's the one where actually they have a SAMHSA grant to co-locate a doctor and a nurse practitioner from Tom Waddell to be there on site. And we've actually done through our fellowship a little examination of that population. But that's the idea, is these community mental health care clinics. And what I think is that these mental health care clinics should be the medical home for the select group of SMI, people with SMI who can't just have trouble accessing primary care. If they should access primary care, they should be going to primary care, right? They should be going and seeing somebody like yours who knows what she's doing. She goes and sees them, treats them for their diabetes or dyslipidemia or whatever. Okay, and I think that effectively that's where the people with severe mental illness are going. When they've done studies looking at where they go, they're accessing psychiatric care. Thank you. They access psychiatric care and they go to the community mental health care clinics. And the issue is that, people talk about, well, maybe we should have a coordination of care model. Maybe we should have co-location. We should just have an internist sitting over there and being at the clinic. That costs actually a lot of money, ultimately, to do that in coordination. And if they came over, how often would they come? Would they just be there kind of permanently, or would be there kind of one day a week? And if they're one day a week, does that really serve all the needs of the patients who are very disorganized, who don't show up right as scheduled for that day a week of care? And people really, but mental health care clinics really want some assistance with this. And I think healthcare reform really is going to provide us with some opportunities. So this is just saying, there's multiple barriers that make it so that these people with severe mental illness can't access primary care. These psychiatric disorders lead to emotivation, cognitive difficulties. They might be really paranoid, so they won't go to the general medicine clinic and go get their care there because they're just too disorganized to be able to do it. Psychiatrists won't initiate treatment because they think it goes beyond their level, scope of practice, so they won't actually do that. Primary care doctors maybe not as comfortable with people with severe mental illness and not really know how to treat this population. And then I think, unfortunately, and this is still true, our systems of care electronically, which is the worst part, electronically are totally separate. So, Kirsten, I don't think right now can read, if she had a patient over at Citywide Focus, she can't read the note by the psychiatrist. The psychiatrist has no access to LCR or eClinicalWorks or whatever it's going to be, so the psychiatrist can't see the labs. There's no way for them, even if they were both treating the same patient, to be able to really communicate with each other effectively or in real time and see what they're doing, as opposed to some system like Kaiser or the VA, where at least you can see, did labs get ordered? Oh, okay, this person started this. And so this is what I was saying before, and this is a little wordy here, but the reason why I think psychiatrists should start screening and treating metabolic disorders is actually a parallel argument to why I think it's worked to have internists prescribe, SSRIs for depression. Okay, so the arguments for that are depression's common. You've got a bunch of depressed patients who are coming to general medicine clinics. They like it better, right? They don't want to be going and seeing a psychiatrist anyway because it's stigmatized. So they go to the general medicine clinic. they go see somebody, they're likely to be seeing an internist, and then there's treatment guidelines. So you kind of know, okay, step one, yeah, start, you know, Celexa. That's fine, I can do that, it's easy. You guys aren't worried about it, it's not like a tricyclic, it's not scary, so, you know, it's easy to do. And untreated depression is super costly to society. I mean, there's vast publications that have been shown, you know, people who get depressed, they don't work as much, it's costly to our society as a whole. Well, there's just the same arguments about this, but in the reverse for the psychiatry patients. You know, they have huge prevalence of metabolic abnormalities. They go to the community mental health care clinics and see people like me. There are treatment guidelines for metabolic disorders, and untreated abnormalities are costly to society. They end up in the emergency room, they end up on the inpatient wards, etc. So how can we do this? So let's get the implementation started. So these are basically the 3 specific aims of my K award. So the first thing that I wanted to do with my specific aim was to just know, where are we right now as far as screening? You know, I showed you that one study that was done by Elaine Murado showing that diabetes testing had not changed over time. I want to say, like, well, maybe it has now, maybe we're doing better. So we need to know kind of where we're at right now. And then specific aim 2, I wanted to understand local barriers that were going on. And so I wanted to do surveys and do focus groups. And then my specific aim 3 was actually implement an electronic clinical decision support system, actually via reverse e-referral. So do you guys know what e-referral is? Mm-hmm. Okay. So rather than the primary care referring to GI, it would be the psychiatrist referring to primary care, and the primary care being able to divert some things that are kind of easy to divert, right? So if it is something like prediabetes or something that potentially could be treated with metformin or something easy, then you can kind of go and do that, and then sure, I'll see them in clinic, but why don't you get that started? Because I think the real problem is this, nobody's getting started, the buck's being packed to somebody else, and then it's just never happening, and nobody's keeping track of it. So I'd like it to just get started. So I kind of got stumped a little bit with my first aim. So my first aim is I wanted to look in San Francisco County. But as I said, here our medical records are separate, right? So I thought, oh, Avatar is going to be so great. It's going to have all these labs. It's going to do all this stuff. They still don't have labs incorporated into Avatar. So labs aren't available in this database. It was, it's not really available. It may be in about a year, and so I hope it will be. But what did become available was actually Medi-Cal data. And that was actually very lucky for me. So I'd had a relationship with the then head of the Department of Mental Health in California. And she had done an initiative, or worked on an initiative, to improve treatment of people with metabolic disorders who had severe mental illness in the state of California through different integration of care projects. So they actually provided me, these are these different demonstration projects they had done, and they said, sure, we'll give you the data so you can analyze some of this stuff. And so I'm actually going to be able to show you guys some of our hot off the press preliminary findings from this that we have. So I have about 50,000 people who have severe mental illness taking antipsychotic medications in the state of California. Okay, they're taking antipsychotic medications both during this pre and post period of this this intervention called Calmend, but that doesn't really matter because Calmend didn't turn out to be super effective. So we'll just say these are patients who are in the system who are receiving antipsychotic medications. And what is their screening like? So first, they're 55% were female. It's got a widely diverse population. It's here in the state of California. They gave me these ages in these weird decades, but there was a good distribution of ages here. And the majority of people had schizophrenia. Only 20% had comorbid drug or alcohol abuse. 56% were on second-generation antipsychotics, which is surprising. I thought there'd actually be many more than that on there. And people were going to receiving healthcare utilization from primary care providers. 65% actually were. But there didn't seem to be very much, at least diagnosed dyslipidemia or hypertension, but this can't actually be accurate.
So that's just by diagnosis. So that means if you didn't look, okay.
Right. If you didn't look, you wouldn't know. So was it diagnosis, or were they being prescribed a medication? And so that requires a lot of extra steps, right, for somebody to actually put the ICD-9 code down and actually implement it. So basically the screening, nothing's happened. It's still only 30%.
I'm sorry, this is a database of visits or of
visits to mental health?
Yeah,
Among
so
Medi-Cal participants?
So it's all Medi-Cal participants who were taking antipsychotic medications,
Yeah.
who had also touched mental health care. So they had already also been seen by mental health care, because they combined the data sets for me. So I got good diagnostic information from the mental health side. So that's often what's lacking in a lot of the Medi-Cal database systems, is they don't have very accurate diagnostic information, like you don't know what they have, whereas this was actually showing what the psychiatrist had diagnosed.
But if the psychiatrist had done it correctly, and then, but they were being treated by a general internist for any of those things, would it have shown up in the database?
If they had seen a psychiatrist at any time during this 2-year period.
Because the diagnoses are based on all visits.
Right, all the psychiatric visits.
What I'm saying is, if I diagnose with dyslipidemia, but you don't code dyslipidemia.
Oh no, that'll show up.
That'll show up.
That will
still
show up.
Okay.
Because I get all the Medi-Cal information.
Got it,
Actually,
got it.
I coded dyslipidemia was determined either by the diagnosis of dyslipidemia or prescription of medications to treat it.
But anyone who any Medi-Cal bill essentially will show up.
Correct, but not dual eligible, which is a problem, right? So I don't have any other Medi-Cal, Medicare information. So women were more likely than men to get screened. So we're talking not about diabetes prevalence, we're talking just about diabetes screening here. And other things is that the youth, and again, this was the high-risk population, they were less likely to get tested than any of the other populations. And I think this, again, is just a matter of people being like, oh, he's a young 20-year-old. Of course he's not developing diabetes, so I'm not even going to check. And then Hispanics were actually more likely to get screened than whites, but not African Americans. People with schizophrenia were more likely to get screened, and then it makes a lot of sense. If you utilized more primary care, you had primary care visits during your year, you were more likely to get screened than if you hadn't. There was other health screening that I've done, so we looked at among those who are eligible according to national guidelines for mammograms, only 25% of the women got screened for mammograms, only 23% of the women got screened for getting pap smears, only 7.5% of the patients get screened for HIV, despite the fact that HIV prevalence is about 8 times the prevalence among people with severe mental illness, and only 6% got tested for Hep C. I've done these different provider surveys of actually all, this is kind of more along the lines of the AIM-2. So I talked to all the psychiatrists, not talked to, but I gave a survey to psychiatrists and all the primary care docs in the San Francisco DPH system of care, and looked at their thoughts about screening of this patient population and where they should get tested. And so we had a very good response rate for clinicians. We had a 69% response rate of psychiatrists and 77% response rate of primary care docs. And the result,
good.
It is. Yeah. So what they thought is that psychiatrists, even if the patient has established primary care, they thought psychiatrists should monitor metabolic risks. And psychiatrists thought this even more strongly than the internists. This is great. Okay. But fewer people thought it was the role of psychiatry to prescribe oral medications to treat elements of metabolic dysfunction. So we specifically said metformin or statins. What about starting those? With psychiatrists, even fewer psychiatrists believing that. So only 15% of the psychiatrists believe that. So this is, I think, one of the problems. Okay, so everybody's saying, yes, psychiatrists should go screen, but our medical record's totally separate. We get the stuff in LC and LabCorp, it gets faxed over to us. The internist is like, well, no, you guys shouldn't be treating. The psychiatrists are like, I don't want to treat. And then the patient doesn't make it to primary care, and then where does it? Nothing happens. So even if they do get screened, nothing happens for them. And then everybody says, this is one of, I asked them their top barriers. Almost 30% thought collaborating with other providers was the top barrier for why this was a problem. I've also started doing focus groups with different groups. So I've talked to administrators, primary care docs, psychiatrists, and then I'm going to be talking to consumers this year to find out their thoughts about doing some of the screening in the community behavioral health clinics. And then my AIM-3, this is kind of more for my future, but I'm going to be wanting to do, again, this reverse e-referral. So I'll tell you my future directions, and then I'd like to kind of open it up to kind of more discussion. I mean, I can talk a little bit more. So I've got some different proposals. These are not grants yet, but some proposals that I have in mind are I submitted an NIMH and IDDK as kind of special RO3, which was just more money, basically. It was like more like $125,000 a year, which was good for a few years. And I applied for this to look at diabetes screening and diabetes prevalence among the Kaiser population. So this isn't to say that the Kaiser population is the best population in the world, but the Kaiser population is great data, it's representative, it's very diverse, economically actually pretty diverse too, and you know they have all the information in there. And that's actually something that has not been examined very well in the data sets, especially differences among different minority populations. I'm also applied with Jim actually in a California HIV/AIDS research program to look at improving HIV testing. So again, this would kind of be along the lines of the same visit that the psychiatrists be doing these metabolic screening, they add on an additional lab for HIV testing, and that just be added on. I'm a co-investigator in an RO1 proposal to reduce smoking cessation among the SMI, and then Jim and I run a public psychiatry fellowship in San Francisco General, and we do a lot of small QI projects with their residents every year. And then I work a lot with inpatient teams and PES on utilization of care projects. So opportunities for partnerships. And so I just wanted to mention a few of the people that I've already done work with here. So obviously Kirsten Moore through the KL2 program, Dean is my primary mentor. And then Irma Mala, I actually started the Warm Hearts group, and Irma Mala is now chairing that. And then Hillary, I actually did a study that I got data here if you're interested in looking at on food insecurity among people with severe mental illness. But I think there's actually a lot of collaborations that are possible between DGIM and the center and psychiatry, and I guess I'd be curious about your guys' thoughts about both my work, but also, especially with Jim here, who knows a lot of the different folks within psychiatry, we can talk about potential collaborations in the future.
That's fine.